Testing, 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 testing. All right, today we're going to talk about hemonc. So if you can have hypercoagulable states, these can be divided into something that you're born with or something that you're acquiring. The most common hypercoagulable congenital state is factor V Leiden. Other things include protein C and S deficiency, antithrombin 3 deficiency. That means heparin won't work. You can have increased homocysteine, homocystinuria, prothrombin G2021, MTHFR gene mutation, and antiphospholipid. That's associated with lupus, RA, pregnancy loss, protein CNS deficiency associated with warfarin necrosis, someone young, history of DVTs, PEs. Acquired hypercoagulable states, surgery is a hypercoagulable state, trauma, cancer, oral contraceptives, nephrotic syndrome because of the loss of antithrombin, increased BMI, smoking, HIT, so you discontinue HIT and add a thrombin inhibitor, DOACs. Pregnancy is hypercoagulable, and just as we age, we also get more hypercoagulable. Cryoglobulin, that consists of factor VIII, fibrinogen, and von Willebrand's factor. Remember, desmopressin releases factor VIII from the endothelial cells. If you have hypercoagulable state, you want to rule out an acquired cause, like we mentioned, something like cancer. And then you want to get tests from the patient and other family members. Let's talk about ITP. So idiopathic thrombocytopenic purpura, you'll have decreased platelets. If they have platelets less than 30, you want to give IVIG, steroids, anti-deglobulin. If there's recurrence, or if the platelets continue to fall and there's bleeding, you want to consider a splenectomy, plus or minus rituximab, plus or minus TPO agonist, like romiplastin or L-tromboplag. If your platelets are above 30, however, you don't need treatment. Most people resolve on their own. In more than 1 year or chronic ITP, you want to consider looking at their bone marrow, viruses like HCV, HIV. If someone has Adams 13 metalloprotease deficiency, then they'll have low platelets and also low hemoglobin because of all the lysing, or so angiopathic hemolytic anemia. And that falls under the category of TTP. And if there's kidney injury, then you want to consider it's HUS because of the complement activation causing kidney injury. Treatment for that is electrophoresis, plasma exchange. And another form of MAHA is DIC. That's a decrease in factor VIII, decrease in platelets, decrease in hemoglobin, a decrease in fibrinogen, and an increase in clotting time. So PT and PTT are elevated. And remember, cryoglobulin has factor VIII in it, as well as fibrinogen. So sometimes you might have to give cryoglobulin for this. And other bleeding causes that increase PT and PTT include vitamin K deficiency. Remember, lupus can also cause a hemolytic anemia that's autoimmune in nature. Things like IgG, IgM. IgM is associated with cold. HCV, HIV can also cause autoimmune hemolytic anemia, as well as cancers like myelodysplasias, and decrease in folate and B12. So again, with lower extremity DVTs, you want to consider, is it something that's occlusive? So if it is occlusive, you want to thrombolyse it. You can use heparin, in which case you would use something like an IVC filter. Also, if they have failed anticoagulation and they develop a PE or DVT, then you also want to put in a filter as well. Increase in homocysteine. Remember, that's a congenital form of hypercoagulability. You want to treat with B6, B9, B12. Pearl. So iron deficiency anemia may have a reactive thrombocytosis as the body sort of revs up. As it revs up its production of red blood cells, the hematopoietic stem cells will also have downstream effects on the platelets. So you might actually have increased platelets with IDA or iron deficiency anemia. You want to treat it with iron, but before you want to test for thalassemias. You want to see if what their hemoglobin A2 is like. And remember, if they have any hemolysis, then all the breakdown products of bilirubin can actually create gallstones. So anemia can broadly be categorized into three main types: microcytic, macrocytic, or normocytic. Microcytic less than 80 MVC. Mnemonic for that is tails, the small tail. So thalassemias, anemia of chronic disease, iron deficiency anemia, lead poisoning, or sideroblastic anemia. Sideroblastic is associated with increased iron overload in the cells, but decreased hemoglobin. Lead will have stippling. Iron deficiency anemia is low ferritin, high TIBC, increased RDW, and a decreased reticulocyte count. Anemia of chronic disease is the opposite, so it has high ferritin, but low TIBC. Thalassemias, they have iron deficiency with normal iron studies and a normal RDW. So again, thalassemias is like iron deficiency, but with normal iron studies. So it'll be low ferritin, high TIBC with a normal RDW. Normocytic anemia, you want to consider medical causes like kidney disease. CKD leads to anemia. Something wrong with the bone marrow. So, where's the issue? Is it at the level of the erythropoietin? So, are the kidneys in trouble, right? Or is it the targets of erythropoietin, like the bone marrow? So, is there aplastic anemia or some bone marrow process? So that's in the production bucket. Maybe they just had post-parvo crisis, right? Or is it in the destruction bucket? So is there some sort of hemolytic anemia, autoimmune, MAHA, right? We just said earlier that TTP and HUS can also cause anemia as well as DIC. Paroxysmal nocturnal hemoglobinuria, HBC, PKD, GCPD, hereditary spherocytosis, infections, right? So all these things can increase your reticulocyte count because your production line is fine, right? But you're actually destroying them, so you'll have increased bilirubin, increased LDH, all the iron is spilling to the blood, and it's being bound by haptoglobin. So the free haptoglobin that we measure is actually low. The treatment for this is to treat the cause. If it's something autoimmune, could consider things like steroids. What's the trigger? Is there a medication like a sulfa drug allergy? You might have to consider surgery. But if you do splenic surgery for anything like destructive, then you have to consider that your body's immune system won't be able to tackle encapsulated organisms. So you have to give prophylaxis for the Shin organisms, Salmonella, Haemophilus, influenza, and Neisseria gonorrhea. Macrocytic anemia, you want to think of B12, B9. There could be, which is megaloblastic macrocytic anemia, or there could be non-megaloblastic macrocytic anemia, things like liver disease caused by alcohol, diamond black fans. Let's review the thalassemias real quick. You can have beta thal and alpha thal. So beta thal has 2 forms, and alpha has 4. There's beta major and beta minor. Beta major is a major deal. That's alpha 2, gamma 2, and you want to transfuse that. Beta minor is alpha 2, delta 2, and that's hemoglobin A2. Beta has BARTs, which is high drops. That's gamma 4. The next alpha is you have 1 out of 4 alpha, and that's the one that you want to transfuse. That's hemoglobin H, or beta 4. And then there's 2 out of 4 alphas, which is alpha thal trait, has a normal electrophoresis hemoglobin. And then there's 3 out of 4 alpha thal, which is just carrier. Moving on to platelets. So you might have 2 big differentiation categories with platelets. Just like with your hemoglobin, you can have high platelets and low platelets, or normal platelets. So the first one we'll talk about is giant platelets, big suckers, Bernard-Soulier, GP1 deficiency. That has low platelets, versus a GP2B3A deficiency, which is Glanzmann, and that has normal platelets. That function is similar to abciximab, GP2B3A. Von Willebrand's deficiency, you'll actually have, it's the most common bleeding disorder, so it's the most common hypocoagulable state. And that's inherited. It is autosomal dominant. And that is an issue with the endothelial surface to platelet adhesion molecule. Von Willebrand's disease will be corrected with the ristocetin rescue. You can treat it with DDAVP or even OCPs. And that will help with the menorrhagia. You can have TTP, which, again, we said earlier was part of the MAHA category. It has low platelets and low hemoglobin because of the defect in Adams T13 metalloprotease. You can have DIC, which is low on everything pretty much except for the clotting time. Clotting time is increased. It has decreased fibrinogen. You want to treat the cause of that. You want to give FFP, platelets if it's less than 10,000. Complications include purpura fulminans and WF syndrome. Hemophilia will have a decrease in factor 7 or 8 production. Hemophilia A is decrease in factor 8. That does correct with mixing. And you also treat that with DDAVP, just like von Willebrand's disease. And you have ITP, which has normal bleeding time. The PT and PTT are normal, as opposed to DIC, which has increased PT and PTT. But again, the platelets are low, right? Because you have antibodies against GP2B, which is the same issue that's wrong in Glanzmann's thrombocytopenia. ITP treatment, it depends on how long they've had it, and if it's recurrent and how many platelets they have. So how do you treat ITP if they have greater than 30,000 platelets and they're not bleeding? No treatment required. What if they have platelet count less than 30,000, but or they have clinically significant bleeding, even though greater than 30? Corticosteroids, IVIG. If the platelet count fails to improve or the bleeding recurs, consider splenectomy, rituximab, thrombopoietin receptor agonist to increase platelet production, something like romiplastim or eltrombopag. Now, what if you have the opposite of anemia? What if you have too much red blood cells? So you will have, this is differentiated by your EPO levels. So your low EPO, high RBCs is primary polycythemia vera. What's the hematocrit going to be greater than? 60%. What mutation will be in the bone marrow? JAK2 kinase. What complications are associated with this? congestion, heart failure, hepatosplenomegaly, heart attacks, strokes. What is the treatment for this? Getting rid of the RBCs, so phlebotomy, thinning the blood with a blood thinner like aspirin, hydroxyurea, interferons. Now, what if you have polycythemia vera, but it's high EPO and high RBCs? This is because this reaction of your blood is a reactive erythrocytosis to something else. So if you have COPD, obstructive sleep apnea, or maybe a cancer, these could be causing secondary polycythemia vera. So you want to get what? Imaging studies, looking for the cancer, look for the renal cell carcinoma, get a chest x-ray to see the COPD. You might have weird sort of inherited autosomal dominant AV malformations like Osler, Weber, Rondeau. They'll have telangiectasias. Other weird syndromes include the porphyrias. So the porphyrias are also inherited disorders. These are production problems in hemoglobin. So you have an increase in accumulation of products called porphyrins. These include acute intermittent porphyria, erythropoietic porphyria, and porphyria cutanea tarda. So the porphyria cutanea tarda is the most common form of this, PCT. It's related to infections with HCV and has the 5 Ps. So pain, polyneuropathies, drugs that precipitate some sort of reaction, cytochrome P450 inducers, alcohol, starvation, port wine stain, and psychological disturbances. So again, these drugs, like the inducers, include OCPs, alcohol, barbiturates. Diagnostic test is what? Your blood and urine porphyrin levels. Treatment, avoid the trigger because these are sort of like an underlying problem in production waiting to happen with a trigger, similar to how DKA needs a trigger or thyroid toxicosis needs a trigger. You can actually treat it with high doses of glucose because that inhibits heme synthesis, provides negative feedback. Here's some just general conditions. So if you have low reticulocyte count with normal platelets, you want to consider something that's destroying the ability to produce. So aplastic crisis. If you have pancytopenia, that's called aplastic anemia. If you have increased reticulocyte count and decreased platelets, something is hiding your platelets and destroying your red blood cells, but your bone marrow is still able to produce. So that's why your reticulocyte count is high. So who's hiding your platelets and eating up your red blood cells? It's your spleen. It's your spleen. Talk to your spleen. Maybe it's ITP. You might need to consider giving steroids if their platelet count is less than 30,000, or if it's less than 30,000 or if it's bleeding, then you want to give something like IVIG. Other weird penias, so you can have thrombocytopenia and anemia and hepatic splenomegaly with delayed puberty and failure to thrive and bone pain, and that's a kid with Gaucher's disease. You can have hemolytic anemias. It could be febrile, non-hemolytic. Excess saline leads to non-gap metabolic acidosis with bleeding. That's because in the lethal triad with trauma, you also have uremia and platelet dysfunction, so your platelet counts will be normal. Pernicious anemia, you want to look out for gastric cancer. Fanconi's can also have pancytopenia, cafe au lait spots, lower tick count. So let's move on to leukemias. All right, leukemia. So these are malignant proliferations of hematopoietic cells. these are categorized by the type of cell involved and their level of differentiation. All right, so let's talk about leukemias first. You can have myelogenous and lymphocytic leukemias. These are disorders of the HSCs, or blasts, that result in unregulated growth and differentiation of white blood cells in the bone marrow. So your bone marrow becomes overwhelmed with blasts, so you're actually not able to produce normal cell lines anymore. So you're actually going to have pancytopenia. You're going to have anemias, low mature levels of white blood cells, so you'll have infections, and low platelets, so you'll have bleeding. Let's just go through a few different types. So AML, which is myelogenous, and ALL, which is lymphocytic. Leukemias affect children and adults. The most common childhood malignancy is ALL. They may also have bone pain in addition to the infections, bleeding, purpura, and pallor and fatigue, signs of anemia. You might also have swollen, bleeding gums and hepatosplenomegaly from the leukemic infiltration and decreased platelets. Leukemic cells may also even affect the skin and CNS. How do you diagnose this? You want to get a smear that shows the blast cells and the CBC, as well as a bone marrow biopsy to classify the leukemia type. So in AML, the leukemic cells are myeloblasts, and in ALL, the leukemic cells are lymphoblasts. There's a specific type of AML, which has the Auer rods, and white blood cell counts could be elevated, but the cells are dysfunctional, so they may actually be neutropenic and will have a history of frequent infections. However, if the white blood cell count in AML is very high, greater than 100,000, there is a risk for complication called leukostasis, where the blasts essentially stop your circulation. There's so many white cells that they cause clots, which lead to ischemia, which leads to pulmonary edema, CNS symptoms, and it can trigger DIC. Treatment for this is chemotherapy. You also want to prevent tumor lysis syndrome with allopurinol or rasburicase. You can also consider for leukostasis syndrome, that complication of AML, you might need to give leukapheresis and hydroxyurea. So essentially plasma exchange. Poor prognosis includes age, if you're very young or very old, if your white count is higher than 50,000, Philadelphia chromosome, the T922, CNS involvement, elevated LDH. So those are the acute leukemias. Now, what about the chronic leukemias? You can have a CML, which is in the elderly. Again, they'll present with fatigue, malaise, infections, lymphadenopathy, splenomegaly. The issue here is, malignant clonal proliferation of functionally incompetent lymphocytes. Again, these accumulate in the bone marrow, the blood, lymph nodes, spleen, liver, anywhere that your blood is going to be going. That's where leukemia is. So the best initial test is a CBC with diff, showing lymphocytosis and characteristic smudge cells, which are fragile cells that are crushed by the slide. Most accurate test is flow cytometry. This will show a CD5 marker on B cells, whereas CD5 is usually a T cell marker. Remember, these patients can present with hypocalcemia following multiple blood transfusions because of the citrate, and the hypocalcemia can affect your heart by causing prolonged QT. That could lead to go to torsades, treat with MAG. Again, diagnostically, you might also have abnormal blood cells, anemias, thrombocytopenias. And the treatment is for CML depends, but usually it's chemotherapy. Palliation is often withheld until patients are symptomatic. Recurrent infections, lymphadenopathy or splenomegaly, and if they have anemia or thrombocytopenia, that's a worse prognosis. Principal presenting symptoms of multiple myeloma are bone pain and fractures due to the lytic bone lesions, renal insufficiency, so your creatinine will be elevated, BUN will be up, hypercalcemia from all the lytic bone lesions, bones, kidney stones, moans, groans, and weight loss. Conditions causing neutropenia in the blood increase the risk of infection only when there's also a decrease in the neutrophils in the bone marrow. So neutropenia is often asymptomatic or presents with signs and symptoms of the underlying disorder causing it, and it is thus usually discovered incidentally on a CBC. So as stated, neutropenia is defined as an absolute neutrophil count of less than 1,500 per microliters. If you have rapidly enlarging lymphadenopathy, you want to be concerned for non-Hodgkin's lymphoma. Get an HIV test. Less common abnormal values will include an M spike on SPEP, elevated LDH, hyperuricemia, hypercalcemia, and pancytopenias from the bone marrow infiltration. You can use PT and INR will be elevated in the following conditions. So liver disease and warfarin, that makes sense. We give those. But then warfarin, remember, inhibits the VDEC. So, vitamin K will elevate your PT-INR, as well as polycythemia, antiphospholipid, and DIC. So the treatment for herpes zoster, acyclovir, simplex also, valacyclovir, as well as foscarnet. Kaposi sarcoma, HHV8, treated with topical alitretinoin and chemotherapy. And parasitic diarrhea, treated with metronidazole, TMP, SMX. Acute signs and symptoms of pancytopenia, again, anemia, pallor, leukopenia, thrombocytopenia, so they'll come in with bleeding, petechiae, infections, cardiopulmonary compromise. PNH presents with the triad of hemolytic anemia, pancytopenia, and thromboses in atypical veins. And so remember the workup for VTE, or vascular thrombotic events, does not need a sort of hypercoag workup unless it's recurrent, or they're young, less than 45, or it happens in these sort of atypical areas like cerebral or mesenteric, liver. Eosinophilia can be seen in transplant, rejection, parasitic infection, Addison's, primary adrenal insufficiency, collagen disease, asthma, other cancers like eosinophilic leukemia or hypereosinophilic syndrome, and this will be greater than 1,500 eosinophils. How do you treat PKD? You give pyruvate kinase deficiencies treated with blood transfusions, managing the symptoms of hemolysis. Splenectomy is not curative, it just reduces the severity of hemolysis. Drugs that can precipitate a hemolytic episode in G6PD. Hemolysis is D-pains, so it's isoniazid, sulfa, dapsone, primaquine, aspirin, ibuprofen, nitrofurantoin. Polycythemia vera presentation symptoms. Let's think about what that is. It's lots of red blood cells, so you can be clotty, you can be itchy from all the bili, all the basophils releasing histamines. with a shower, so you'll have itching with a hot shower. Neuropathy, burning and pains in feet due to microvascular thrombotic events hitting the nerves. Headaches from hyperviscosity syndrome, and congestion and bruising. Platelet disease, whether it's qualitative or quantitative, increases bleeding time and superficial bleeding, so the gums, nose, females menorrhagia, excessive bleeding following circumcision. Deeper bleeding, such as hemarthrosis and hematomas, is not typically seen with platelet disorders. Those are mostly symptoms of coagulation cascade defects, so factors 7 and 8 with hemophilias, B and A. Remember, pernicious anemia, it's autoimmune, but it can also lead you to believe that someone has underlying gastric adenocarcinoma. Remember, if you have a left shift in the oxygen saturation curve, that's caused by metabolic alkalosis, hypothermia, an increased fetal hemoglobin, and a right shift, you have acidosis, increased body temp, exercise, high altitude. If someone has a exposure to HIV or a high risk of exposure to HIV, prophylaxis post-exposure as a 3-drug regimen. In hyposplenia or functional asplenia, common infections include strep. This is the shin. So this is strep pneumoniae, Haemophilus influenza, Neisseria, Salmonella, Staph aureus, pneumonias caused by Mycoplasma, Chlamydia, Legionella. Remember, HIT occurs 5 to 10 days after a heparin exposure. Change them to a DOAC, factor 10A inhibitor, direct thrombin inhibitor. Again, VTE, unprovoked, hypercoag disorder workup only if they're young, if they have recurrence, positive family history of hypercoagulable states, or VTEs in unusual places. Hodgkin's lymphoma is diagnosed by biopsy, lymph node. Reed-Sternberg, inflammatory background. Sideroblastic anemia, iron studies show an iron overload state, so you have increased serum iron. You'll also have high ferritin, which is kind of like anemia of chronic disease. But then you also have high transferrin saturation, but you have reduced TIB. So it kind of looks like anemia of chronic disease that way. You have high ferritin, low TIBC. But you'll have high serum iron. Chronic hemolysis can present with jaundice, frontal bossing, leg ulcers. Iron deficiency anemia has low ferritin, low serum iron, and high TIBC. Remember, sideroblastic looks like anemia of chronic disease, which is high ferritin, low TIBC. All right, moving right along. What's the etiology of the chipmunk facies and hair on end radiographic appearance in beta thal major, which does need blood transfusions as treatment? That's expanded peripheral hematopoiesis. ITP typically occurs as isolated thrombocytopenia without any other hematological abnormalities. Presenting symptoms of multiple myeloma, CRAB, lytic lesions, hypercalcemia, weight loss, renal insufficiency. In hyposplenism, remember you can have meningitis, strep pneumo, bacteremia, strep pneumo, pneumonia, atypicals, mycoplasma, chlamydia, legionella, osteomyelitis, salmonella, staph aureus, as in the setting of hyposplenism. Some causes of thrombocytopenia: infections like viruses, HIV, measles, mumps, rubella, parvovirus, hep C, bacteria. Sepsis can also cause thrombocytopenia. Some drugs can also cause it due to peripheral destruction or bone marrow toxicity. For example, quinine, linezolid, dropping platelets, valproate as well. Alcohol can cause thrombocytopenia. Alcohol can really cause pretty much everything. Nutritional deficiencies, you need copper, B12, B9. And bone marrow disorders, right? So the source of the production, and not just the building blocks, but sometimes the source, like leukemias, lymphomas, myelodysplastic syndromes, PNH. The difference between TTP and HUS is very minimal. Historically, we're taught that TTP has neurological symptoms more commonly, and HUS mostly has the acute renal failure. So those are the main two differences. TTP, mostly neurological, mild renal. HUS is the MAHA with mostly renal failure. Vitamin K malabsorption or deficiency will mess up with your factors 2, 7, 9, 10 clotting factors. So if you're vitamin K deficient, or if your liver, which is the source of the clotting factor production, is broken, then liver disease can also mimic vitamin K malabsorption. The way to distinguish between the two is that you check factors 5 and 7. Checking those will distinguish between liver dysfunction and vitamin K deficiency. Remember, vitamin K is 2, 7, 9, 10. If you check 5 and 7, then you'll know if it's the liver or if it's just vitamin K. Diagnostic tests for suspected von Willebrand's disease, which is the most common inherited cause of hypocoagulation. You want to check a plasma von Willebrand's factor antigen. Aristocetin cofactor assay will rescue it, and a factor VIII activity. What are the coagulation findings in terms of bleeding time, PT and PTT with someone who has hemophilia? Bleeding time is normal. PT is normal. Your PTT, however, is prolonged. Your PTT is your intrinsic cascade. So that's pretty much everything except for 7. So if you have, you need to measure factors 8 and 9 levels in anyone with a prolonged PTT. Remember, prolonged PTT does correct with a mixing study. Basically, a mixing study supplies the deficient clotting factors and reassesses with coagulation. The differentiation between factor deficiency, like hemophilia, and the presence of a clotting inhibitor, like antiphospholipid antibody, is that the antibody will not allow a mixing study to correct the bleeding time. So PTT will stay prolonged if there's a clotting inhibitor, like an antiphospholipid antibody. If you have a lytic lesion in the epiphysis on X-ray, you want to think of a soap bubble appearance with what cell tumor? And that's giant cell tumor. If you have bleeding with megakaryocytes on bone marrow biopsy, the most likely diagnosis is ITP. Now, you don't usually do bone marrow biopsies for ITP, but the reason behind the megakaryocytes is that you have autoimmune production of IgG against platelet antigen, GP2B. It's isolated thrombocytopenia with megakaryocytes on peripheral smear. In children's, you usually just have skin manifestations. Sometimes you do have bleeding, and if they do have bleeding or skin manifestations only, then there's differences in treatment. So if they only have skin manifestations, you just observe. But if children are bleeding, then you want to give IVIG or glucocorticoids. And that's the treatment for ITP in children. The treatment of ITP in adults depends on the platelet level. If the platelets are greater than 30,000 without bleeding, just wait and watch. If their platelet levels are less than 30,000 or they're bleeding, treat them just like the kids. IVIG, glucocorticoids. They'll have had a recent viral infection or some sort of maybe even pregnancy. Someone develops thrombocytopenia 5 days after heparin infusion, you want to consider HIT. Switch them to a DOAC. If you have someone with a negative GCPD assay, a low haptoglobin, high LDL, smear showing bite-sized cells, and they just took Bactrim, they have G6PD deficiency. Remember, the activity on the assay is normal during an acute episode, as the deficient RBCs are the ones being hemolyzed. So only the active red blood cells that are being assayed will have active G6PD. So it could be a false negative test. It's X-linked, most often in men, Asian, African, Middle Eastern descent. Usually there's some sort of oxidative stress like a drug, isoniazid, sulfa, dapsone, pyrimethamine, aspirin, ibuprofen, nitrofurantoin. Or it could be an infection or something food like fava beans. They'll present with dark urine, jaundice, hemolytic signs, abdominal back pain. And treatment is to reverse or remove the agent and supportive care. If you have a kid with petechiae of the tongue and lips, with multiple papular telangiectasias, then and they're having nosebleeds, digital clubbing, maybe even. It could be that they have shunts as part of hereditary telangiectasia or oslo-rubberandu. And so the clubbing is due to low oxygen because there's an AVM in the lungs causing a right to left shunt with hypoxemia. This will lead to increased erythropoietin, and so this will be a secondary, possibly a secondary polycythemia due to reactive thrombocytosis, and they'll have these nosebleeds, epistaxis. These AVMs can also be present in other areas, not just on the lips and tongue. Could also be in the GI tract, small bowel especially, lung, causing hypoxemia, like I said, as well as liver, brain, skin. Smudge cells, think CLL. Complications of CLL include infections, autoimmune hemolytic anemia, and secondary malignancies or Richter transformation. So it could progress to something like diffuse large B cell. Well, let's go through blood transfusion reactions. If you have signs of respiratory distress and non-cardiogenic pulmonary edema, this is TRALI caused by donor antibodies. If you have pretty much immediate signs and symptoms of low blood pressure, angioedema, respiratory distress, these are anaphylactic reactions caused by recipient anti-IgA antibodies. If you have flushing, angioedema, itching, urticaria, this is likely allergic urticarial caused by recipient IgE mast cell activation. If you have within 2 to 10 days after a transfusion, positive direct Coombs test, mild fever, hemolytic anemia, this is usually delayed hemolytic caused by an amnestic antibody response. If you have fevers, chills within a few hours of the transfusion, but no hemolysis, then this is febrile non-hemolytic. It is the most common reaction of blood transfusions, and this is caused by cytokine accumulation during blood storage. If you have an acute flank pain, hemoglobinuria, renal failure, fever within an hour of transfusion, this is acute hemolytic. This is direct Coombs test positive, has pink plasma. It's caused by an ABO incompatibility. And then TACO is going to be cardiogenic edema. If you have someone who's 55, has weight loss, night sweats, splenomegaly, a white count of 110,000, what's the diagnosis and treatment? It's most likely a gentleman with CML, given the leukemoid reaction, be lab positive. Treat it with a tyrosine kinase inhibitor, especially if it's Philadelphia chromosome. You want to use the imatinib for the BCR-ABL fusion protein. It can also be used to treat ALL if it has the 922 translocation. When you evaluate for anemia, you want to get the hemoglobin on CBC, and then if they have a normal MCV, you want to get the retic count. If it's a low reticulocyte count, it means the production is not working. Maybe they're being crowded out by immature lymphoblasts or myelogenous cells, like in leukemia, or maybe there's aplastic anemia or crisis or infection. If the reticulocyte count is high, it could be something like hemorrhage or hemolysis. So the thalassemias, iron studies, alpha thalassemia minor and beta thalassemia minor, these will have a low MCV, so they'll be microcytic, but their RDW and RBC count will be normal. Their iron will be high, and their ferritin is going to be high, and their TIBC is low. So it almost looks like a anemia of chronic disease, like that. The difference with iron deficiency anemia and thalassemias is that iron supplementation will increase the hemoglobin, whereas with alpha thal minor and beta thal minor, iron supplementation does not increase or improve the hemoglobin. What is an acute sickle hepatic crisis? Basically, repetitive sickling causes destruction of RBCs. It leads to intra and extravascular hemolysis, so jaundice, scleral icterus, anemia. And the sinusoids also in the liver get occluded as the RBCs are sequestered, causing tissue ischemia and infarction, transaminitis, right upper quadrant pain, systemic inflammation, fever. These acute pain episodes are more common during pregnancy. Repetitive episodes are associated with increased fetal complications like growth restriction, preterm birth, as well as maternal morbidity like preeclampsia, placental abruption. You want to treat the triggers of vaso-occlusion like hypoxia, pain, hydration. What's the earliest manifestation of sickle cell disease in young children? And that's dactylitis, sausage fingers, hand, foot. The treatment is pain control, hydration. You can apply heat because cold triggers intravascular sickling and vasoconstriction. Acute treatment of dactylitis does not include hydroxyurea. That reduces the frequency of these vaso-occlusive crises, but they take months to take effect. In the meantime, you also want to do maintenance therapy like a pneumovax, penicillin until age 5, or whenever they have their spleen taken out. You want to give them prophylaxis for any encapsulated organisms, as well as folic acid supplementation. Splenic sequestration crisis in sickle cell usually occurs, there's reticulocytosis and splenomegaly, often caused by a virus, parvo. In this case, aplastic crisis, the reticulocyte count is low because you're not able to make the RBCs. If you're just having sequestration, though, a sequestration crisis, your RBCs are being sequestered in your spleen, so you'll have an enlarged spleen. This occurs in patients and children, usually around 2 years old. Generally causes autosplenectomy, and in this case, our RCs will be high because your bone marrow is still fine. What's the empiric antibiotic therapy for a 4-year-old with suspected osteo? If the rates of MRSA are low, you want to do nafcillin, cefazolin, gram-positive coverage. If MRSA is suspected, though, you want to do Vanc or Clinda. Osteo and sickle cell, most commonly caused by Staph aureus, but they do have an increased risk for developing salmonella. They essentially have functional asplenia due to the splenic sequestration leading to autosplenectomy. So in healthy children, most commonly osteo is caused by Staph aureus. Low likelihood of MRSA, give nafcillin or cefazolin. High likelihood of MRSA, give Clinda or Vanc. And in children with sickle cell, they're most commonly caused by Salmonella osteo or Staph aureus osteo. So you do the same thing as above, but you also add a third generation cephalosporin like ceftriaxone. If you have someone with surgery or needing anticoagulation for any other reason and they suddenly develop a decrease in platelets, you want to consider HIT. And if it's HIT type 2, usually it's an antibody-mediated reaction against platelet factor 4. This could lead to thrombosis and acute limb. You want to avoid heparin in this patient in the future due to the risk of recurrence. And if you're trying to restart warfarin, you need to do so only once the platelet count recovers. In terms of risk factors for colon cancer, alcohol is a bigger risk factor than cigarette smoking if the smoking hasn't been more than 30 years. Even moderate alcohol consumption will increase your risk of smoking, and you can also see decrease in folate because alcohol interferes with folate absorption, and heavy drinkers may also have decreased folate intake. All right, if you have a 66-year-old man who comes in with fatigue and anorexia, splenomegaly, lymphadenopathy, diffuse large B-cell lymphoma, diagnosis on lymph node biopsy, he gets chemotherapy and rituximab, has normal kidney function prior, receives respirocase with the chemotherapy, and then after 4 days, the lab results show signs of kidney injury, creatinine's elevated, he has hyperphosphatemia, hyperuricemia, and hypocalcemia, and hyperkalemia. You might want to think about tumor lysis syndrome. What would explain this? So what's going on here is tumor lysis syndrome. The uric acid is actually suppressed by the respirocase. However, AKIs with respirocase, which is a urate oxidase analog, can still happen because respirocase does not affect the calcium and the phosphate, and so those depositions can cause stones, and it can cause AKIs. If you have someone with a macrocytic anemia and they're taking certain drugs, that can be the cause of it due to folic acid deficiency. Folic acid deficiency, you want to think of phenytoin, Bactrim, and methotrexate. If you do need to rescue someone's anemia due to folate deficiency, you want to use folinic acid, which is more potent than folic acid. The other name for folinic acid is leucovorin, so methotrexate with leucovorin, folinic acid. Going back to tumor lysis syndrome, a complication of that is renal tubular obstruction. Basically, this is caused because of calcium phosphate stones, which cause, even though you have uric acid reducing therapy, patients with chemotherapy may still develop an AKI due to renal tubular obstruction and direct cellular injury or acute nephrocalcinosis. And you can reduce this risk by maximizing the GFR and urine output with prophylactic IV fluids. If someone has a urethral obstruction, they should have bladder fullness. If someone has renal blood flow impairment, that's a pre-renal AKI, but unlikely if someone already had IV fluids pre-treatment. And then acute tubular necrosis or acute interstitial nephritis will typically have some sort of casts or cells, white blood cells, muddy brown casts, pyuria. So drug-induced tubular necrosis or tubular interstitial hypersensitivity, both of those should have some sort of casts or cells. Certain chemotherapy drugs can be cardiotoxic, like doxorubicin, daunorubicin, and these are related to the cumulative dose, so they are dose dependent, and the risk of cardiotoxicity is increased with someone with pre-existing low ejection fraction. So you generally need a radionuclide ventriculography, also known as a multi-gated acquisition scan. And this will help quantify and reproduce the EF pre and post chemotherapy. If someone's EF reduces by more than how many percentage points, you want to discontinue the therapy. And that percentage point is 10 or more. You want to discontinue therapy. And below this EF, you don't want to do anthracycline chemotherapy at all. And that would be below 30%. Let's talk about bones. So there are secondary causes of osteoporosis. They can be divided into different organ systems. So control of calcium, you want to think of the endocrine system and the renal system, right? So your kidney disease, your hyperthyroidism, hyperparathyroidism, hypogonadism. There's also intake issues with calcium and phosphate or vitamin D, absorption issues with that. So you might have malabsorption, celiacs, or Crohn's disease, or liver disease, or you might have medications that prevent absorption, or that cause bone breakdown, like glucocorticoids. So you also want to consider inflammatory diseases, things that break down bone, lytic lesions, things like multiple myeloma, alcohol use, or mobilization. So if you are concerned for multiple myeloma, you need to get a serum and urine protein electrophoresis. If someone is having bone pain and there's a question of a cancer, you want to get a what bone scan? A radioisotope bone scan. If there's a 67-year-old man coming in with a history of right shoulder pain, he has diabetes, it looks like it's uncontrolled, but also elevated PSA and nodular prostate on exam, and he's getting transrectal prostate biopsy, you want to get a radioisotope bone scan. Just because someone has diabetes and you're thinking it could just be adhesive capsulitis doesn't mean you just give them physical therapy. If someone has full range of motion and no focal findings, it's unlikely to be something amenable to physical therapy. Just because they have neuropathy doesn't mean that gabapentin is the option. And because they don't have any neuropathic pain, it's more likely that's something that they're trying to confuse you with. CT scan is good for soft tissue, but it's not very good for bone or bony metastasis. And dual energy X-ray is that's a DEXA scan, so that's used to measure bone density, and that's not useful for staging disease, which is what we'd be doing. If you have someone who has suspected metastases, you want to get initial biopsy of the metastatic site. So the easiest target for biopsies are superficial locations because they're low risk and minimally invasive. If lymph nodes are not involved, biopsy of distant met site like liver, adrenal gland, or bone should be attempted. Brain biopsy is rarely performed due to the high invasive and high risk nature of the procedure. If you need to reverse warfarin, go for PCC and IV vitamin K. Prothrombin complex concentrate contains the vitamin K dependent clotting factors that warfarin inhibits, and it normalizes your INR less than 10 minutes after administration. Vitamin K takes about 12 to 24 hours for full effect, but it's always sort of given in adjunct with PCC. So in life-threatening hemorrhage situations, warfarin reversal is with what? 2 agents, PCC and vitamin K. Your fresh frozen plasma, that's considered second line. It contains a large volume that needs to be administered, and there's usually a delay for blood compatibility tests. So it's typically only used when PCC is unavailable. Here's a bridge with ophthalmology. So say you have a concern for a pigmented lesion on fundoscopic exam, and it's an 8 millimeter by 1 millimeter lesion. Skin exam is otherwise unremarkable. What would be your next step? Next step is repeat the exam in 3 months. Ocular melanoma is frequently identified on ophthalmologic exam. That's usually done for other reasons. So these asymptomatic patients will have small lesions, diameter less than 10 millimeters, thickness less than 3 millimeters, and they can be managed with close follow-up. This is especially useful in asymptomatic patients. However, you might need to use other diagnostic imaging studies if someone has ocular symptoms like floaters or pain, blurry vision, visual field abnormalities. In that case, you want to get an ultrasound or any staging with an MRI. And if it does come back symptomatic and you're concerned for a choroidal melanoma, definitive treatment is what? Radiotherapy, radiation. You only want to remove a very large tumor or extrascleral extension tumors of the eye with a nucleation, but only once it's quite large. Remember, along the lines of multiple myeloma, you can also have cryoglobulinemia, which can sometimes look like multiple myeloma. It might also be, in fact, multiple myeloma. So remember, multiple myeloma can produce cryoglobulins, type 1, that precipitate intravascularly. So you might have someone who comes in with crab symptoms as well as this horrible occlusive, embolic manifestations of basically what it is. It's microvascular cryoglobulin precipitation, especially less than 37 degrees Celsius. And that's associated with plasma cell dyscrasia. So Waldenstrom's multiple myeloma. The pathophys of that is the cryoprecipitates and the hyperviscosity. You'll have elevated monoclonal spike on SPEP, ESR, but you might have normal complement. This is opposed to mixed cryoglobulinemia, types 2 or 3. These are more associated with what? Not necessarily cancers, but viruses, HCV, HIV. These are B cells that get hyperactivated, leading to IgM rheumatoid factor that's bound to polyclonal IgG. So these are immune complexes that deposit, causing vasculitis, palpable purpura, glomerular nephropathies, arthralgias, neuropathy, viral hepatitis. And in this case, you might have positive cryocrit as well, but you'll have a decrease in complement. And you'll have rheumatoid factor autoantibodies as well as viral or ANA. And so that's the difference between cryoglobulinemia type 1 and mixed. Complications of malignancies include compressive mass effects. One of these is superior vena cava syndrome, secondary to a what malignancy? A lung malignancy. 80% of these are caused by what kind of carcinoma of the lungs? Bronchogenic carcinoma. These present with a neck fullness, neck pain, can progress to hoarseness, dysphagia, chest pain, syncope. On exam, you'll see the dilated veins of the neck, maybe even cyanosis, ocular proptosis, lingual edema, collateral veins in the thorax. And what's the best test for this, imaging-wise? You might think MRI, but it's CT. It's contrast CT scan. This will let you see if there's any pulmonary mass, metastases, or intravenous thrombus. Similarly, you might have a Pancoast tumor of the superior pulmonary sulcus. And this can present with shoulder pain, back pain in a patient who has right lower extremity hyperreflexia, smoking history. Spinal cord compression develops in 25% of patients with Pancoast tumor and may result in paraplegia. So early recognition and therapy with steroids, surgery, radiation is crucial to preserve neurologic function. They may also have Horner syndrome, which is pupil asymmetry, but that's not a poor prognostic sign, and it's not immediately dangerous. Along the lines of cancer in the heme world, we have polycythemias, right? So hemoglobin greater than 16 in women or 18 in men. This could be either primary or secondary, and the way you differentiate is getting a what level? An erythropoietin, EPO level. The way your EPO can tell you where the RBCs are coming from is if it's primary, then your EPO is going to be low. That's in something like a chronic myeloproliferative disorder. Versus it's high when there's a reaction to something. It's low oxygen, hypoxia levels because of COPD, OSA, or it's high because of cancer like renal cell carcinoma, hepatocellular carcinoma. Other causes of high EPO secondary polycythemia vera includes hydronephrosis, ectopic EPO production. Primary polycythemia vera is EPO is low because of the negative feedback, and this can be due to something like a primary disorder. You want to get a JAK kinase test and you might need to treat with a JAK inhibitor, hydroxyurea, phlebotomy. Remember, you could have relative polycythemia, which is due to what? It's relative due to your plasma volume. So that's in dehydration or in burns. And remember, the polycythemias could be due to high EPO, but the differentiation in that is oxygen saturation. If you have low oxygen saturation, that's usually lung disease, congenital heart disease, high altitude. If it's normal oxygen saturation, you want to think of malignancy. Other chronic myeloproliferative disorders include myelofibrosis. This is obliteration of the bone marrow due to fibroblast activity, often associated with enlarged organs, teardrop RBCs, and a dry tap on bone marrow biopsy. Other forms of myeloproliferative disorders include essential thrombocythemia. These are massive proliferations of megakaryocytes and platelets. Symptoms of all these clots and ineffective coagulation includes bleeding and clots. So you'll have thrombosis. Blood smear will have increased platelets, which may be large or malformed. So one of the most common causes of secondary polycythemia with elevated EPO but low oxygen saturation is chronic hypoxia. And sometimes sleep apnea will need a diagnosis with nocturnal oximetry, as these patients may have normal daytime oximetry. Also want to grab a carboxyhemoglobin level to exclude carbon monoxide poisoning, especially those who smoke heavily. So let's talk again about the leukemias. In the elderly population, you might see chronic leukemias. Chronic leukemias can be divided into CML, myelogenous, and CLL, lymphocytic. Median age of CLL is around 70, and this is significant lymphocytosis. The staging of this is the Ray and Benet treatment prognosis takes into account physical exam findings and blood findings. So the presence of any of these following indicate a worse prognosis: organomegaly of the liver or spleen, lymphadenopathy, cervical, and blood findings of anemia or thrombocytopenia. The cell markers for these are usually B cell, so they'll have CD20, CD23, and inappropriately they'll have a T cell marker like CD5. On smear, they'll have a smudge cell appearance. Their anemia is due to the autoimmune hemolytic anemia. And importantly, these can undergo malignant transformation into aggressive lymphoma, most commonly diffuse large B-cell lymphoma, and that's called the Richter transformation. Adult males can also have a hairy cell leukemia, which is associated with a BRAF mutation. Treatment for this is cladribine and pentostatin, and this is because it inhibits the adenosine deaminase. These patients usually present with splenomegaly and pancytopenia. These will have what positive stain? And that is a tartrate-resistant acid phosphatase, or positive TRAP stain. However, these are largely replaced by flow cytometry. Going back to CLL, patients usually have a median survival of how many years? 10 years. Infection and secondary malignancy is usually the principal causes of death. And again, these are confirmed by peripheral smear and flow cytometry. You do not need a lymph node or bone marrow biopsy for CLL. It's just to round out the other leukemias, you could have AML. The median onset for that is about 65. You can have the APML, formerly the M3 AML, which is associated with the T1517 mutation that responds to vitamin A. And the most common presentation of that is DIC. This has risk factors including prior exposure to chemotherapy or radiation, or the myeloproliferative disorders we talked about, like polycythemia vera, myelofibrosis, essential thrombocythemia, as well as trisomy 21. There's also chronic myelogenous leukemia, CML. This has several stages to it. It can be in its latent phase, or it could also be in a sort of transforming phase. So this can also transform into AML or ALL and cause a blast crisis. This presents with splenomegaly and a very high leukocytosis, which will have a differentiation from just a benign neutrophilia leukemoid reaction, in which case those are normal neutrophils. However, in CML, the myelogenous neutrophils are proto myeloblasts, and so they're not functional, and so there's lots of them, but they'll have a very low intrinsic enzyme function, and so they'll have a low LAP level, or leukocyte alkaline phosphatase. CMLs usually respond to what type of inhibitors? And these are tyrosine kinase inhibitors, especially BCR-ABL. A fun pathology corollary is that neutrophils have these types of inclusion bodies, and that's DOLI. On hairy cell leukemia, they're named such because cells have these filamentous hair-like projections. They look fuzzy. And rounding it out with ALL, acute lymphoblastic leukemia, or lymphoma as well. These most frequently occur in children, ALL, T cells and B cells. These can present as a mediastinal, anterior mediastinal mass associated with Down syndrome. Could present with infections. They have positive TDT markers of pre-T and pre-B cells, these progenitor cells, as well as a CD10 marker, which is a pre-B cell. And these may also spread to the CNS and testes. So you need to do a prophylactic treatment for ALL. And the better prognosis with ALL in terms of their chromosome is 1221. Just to review, platelet disorders, you can have defects that cause increased bleeding time. And the symptoms of this is ecchymosis, nosebleeds, right? But the differentiation is, what do they do with the bleeding time and the platelet count? So in isolated platelet count decrease, you'll have all the other cell lines are fine, and that's likely due to ITP, or immune thrombocytopenia. This pathology is antibody mediated, so this could be either primary idiopathic or secondary to an autoimmune disorder, pregnancy, viral illness, malignancy like a cancer, or drug reactions. Treatment for this depends on the platelet count, and if they're bleeding or if they're children or adults greater than 30,000, you generally, and no bleeding, you don't do anything. If they're bleeding, you want to give steroids and IVIG, or if they have less than 30,000, you want to give steroids, IVIG, and potentially rituximab if it's refractory or even a splenectomy. This is clearly different from TTP, which causes schistocytes because of the inhibition or deficiency of Adams 13 metalloprotease. So you'll have these multimers of von Willebrand's factor that cause platelet adhesion, aggregation, and thrombosis, which leads to neurological and renal symptoms, but then also leads to lysing of red blood cells, causing hemolysis. So you'll have increased LDH, low haptoglobin, and possibly even fevers. And treatment for this is you have to get rid of the platelets that are bad. So plasma exchange, plasmapheresis, and reduced inflammation with steroids. This is on the same spectrum as TTP with HUS. It's very similar clinical presentation and is the same treatment of plasmapheresis. You want to avoid antibiotics in this case because this will actually worsen the HUS. It's commonly caused by Shiga-like toxin of the EHEC bacteria. Occurs in the setting with bloody diarrhea, could be pregnancy, medications such as gemcitabine, or cyclosporine. Treatment purposes for both TTP and HUS. These are microangiopathic hemolytic anemias that will be invariably fatal if they're not treated quickly. So that you need to do plasma exchange, track the platelets and LDH counts daily until they normalize. And again, more commonly, TTP has neurologic symptoms and HUS has acute renal failure. And just going back to ITP, ITP, if children only have cutaneous symptoms, you can observe, and otherwise you give glucocorticoids, IVIG, or anti-D if they're bleeding. In adults, you only observe if they have cutaneous symptoms and platelets greater than 30,000. But once they're bleeding or they have platelets less than 30,000, you want to do steroids, IVIG, and anti-D. Remember, with lymph nodes in general, painless lymphadenopathy that's persistent and abnormal should be biopsied, especially if someone has associated EBV, mono that didn't resolve. These should resolve within a couple of weeks. If they persist, you want to do a biopsy to find any underlying lymphoma. So don't send the kid home just because he just had mono. If it's persistent and it's painless, then remember, painless lymphadenopathy needs to be worked up. So how do you manage supratherapeutic INR in someone who's on anticoagulation, such as warfarin? The treatment depends on what their level of INR is and if they're bleeding or not. So if there's any serious bleeding, you want to hold the warfarin, give PCC and IV vitamin K. And that's PCC, prothrombin complex concentrate, and IV vitamin K. FFP takes too long. Now, if the INR is greater than 10 and there's no bleeding, so very high INR with no serious bleeding, hold the warfarin, administer high-dose vitamin K orally, and that's it. Anything below that, if it's 4.5 to 10 and no bleeding, hold the warfarin and resume once the INR is therapeutic. You could consider low-dose vitamin K if there's an increased risk for bleeding. But again, this needs to be administered orally if there's nothing serious or life-threatening going on. And if there's no bleeding and the INR is less than 4.5, don't consider the vitamin K. Just hold the warfarin for 1 or 2 days, or even consider decreasing the dose. So again, patients with a supratherapeutic INR, less than 4.5 on warfarin, no serious bleeds, just hold the warfarin and restart once it's therapeutic. Patients with a supratherapeutic, above 4.5 but less than 10, and an increased risk of bleeding, you do want to hold the warfarin but also give oral vitamin K. And if there's any serious bleeding or life-threatening, then you give IV vitamin K, hold the warfarin, and PCC to reverse the warfarin. Remember, cytochrome P450 inhibitors will increase the warfarin effect. So that's why things that activate CYP450 can increase the warfarin effect and make use super therapeutic. Just to review the cytochrome P450 interaction, so things that induce it and increase the warfarin effects. Inducers like modafinil, chronic alcohol, St. John's wort, phenytoin, phenobarbital, HIV medications like nevirapine, TB meds like rifampin, antifungals like griseofulvin, and antiepileptics like carbamazepine. So most chronic alcoholics steal fen-phen and never refuse greasy carbs. Things that inhibit cytochrome P450 is sickfaces.com. So mood medications like sodium valproate, again TB meds like isoniazid, remember B6 was that, PPIs like cimetidine, antifungals like ketoconazole, fluconazole, alcohol abuse but acute alcohol abuse, chloramphenicol antibiotics, erythromycin, clarithromycin, sulfonamide, ciprofloxacin, again PPIs like omeprazole, cimetidine, antiarrhythmics like amiodarone, metronidazole, again antibiotic, and grapefruit juice, but you'd have to have a lot of grapefruit juice for that. So the substrates that are interacted by these are always think when outdoors. Anti-epileptics, theophylline, warfarin, and oral contraceptives. So the three big ones from that is OCPs, warfarin, and seizure meds, right? So your seizure meds might not work as well if you take PPIs or antibiotics. Your warfarin and oral contraceptives might not work as well either. So in the previous case, if you had someone that is taking a medicine that induces cyclone P450, then maybe your oral contraceptives aren't working anymore. So like that's the example of St. John's wort. And if someone is taking like amiodarone for their antiarrhythmics and they're also on warfarin, then that can actually inhibit cyclone P450 and you might have more warfarin, so you're super therapeutic and you're very anticoagulated. Just to throw back to tumor lysis syndrome, the optimal treatment involves a few things. So you want to decrease the uric acid levels with rasburicase. You want to decrease the calcium phosphate stones with IV fluids. And you want to track how your heart's doing with all that potassium floating around. So you want to put them on telemetry, make sure you have aggressive electrolyte monitoring and treatment. So the mechanism is urate oxidase metabolizes all the uric acid to allantoin, and that's highly soluble and easily excreted in the urine without risk of stone precipitation. Now, urate oxidase is an enzyme that is in most mammals, but it's not naturally present in humans. So we don't create the allantoin naturally. So our uric acid levels will build up, and the treatment for TLS is IV fluids to wash out the stones, but also just to prevent the stone precipitation in the first place by reducing the uric acid levels. So you can use a urate oxidase analog like rasburicase, which is recombinant, highly successful, useful in reducing uric acid that's already accumulated. In contrast, xanthine oxidase inhibitors like allopurinol and febuxostat, they simply prevent the production of additional uric acid. But this leaves the existing levels of elevated uric acid levels unaffected. So that's why you need the urate oxidase analog to reduce those existing levels of uric acid. This is accomplished by rasburicase. Now, of note, this is a drug that's contraindicated in patients with what type of deficiency due to the risk of hemolysis and methemoglobinemia. That's G6PD deficiency. So you contraindicated in G6PD, do not use rasburicase. Just as a aside with the nephrology studying, so you have kidney stones that can lead to hydronephrosis, pyelo. You know, if your creatinine isn't resolving, then you want to consider a urology consult. Most common kidney stone is what kind? It's calcium oxalate. That presents in people with hypercalciuria and normal calcemia. This is radio opaque, so it will be visible on X-ray, and treatment for this is thiazides, which reduce urine calcium, citrate, which causes citrate calcium chelation, and a low sodium diet. So this can result from a vitamin C overdose, malabsorptions like Crohn's disease, ethylene glycol ingestion, or even a low calcium diet. Other kinds of calcium stones, but less common than calcium oxalate, is calcium phosphate. This has it precipitates with increased urine pH. These are also X-ray opaque, visible. The other ones that are radio opaque are the staghorn calculi or ammonia magnesium phosphate, the MAP stones. This also precipitates with increased pH in the urine. And faintly radio opaque on X-ray is cystine stones. These have low pH in the urine when they precipitate, and uric acid stones also have low pH. And these will be associated with hyperuricemia, gout, TLS, and treatment for that is alkalinization of the urine, as well as allopurinol and resvuricase. So you want to remove the production of uric acid with allopurinol, remove the existing uric acid with an oxidase analog like resvuricase, fluids to help pass it with the stones, and then alkalize the urine to prevent the precipitation. So let's talk briefly about clotting. So you can have hypercoagulability that's either inherent because you were born with it. It's something that's passed down. It's congenital. It's in the family. Or it's something that's acquired. You have something and then you develop hypercoagulability. So the most common inherited cause is what? And that's factor V Leiden. It's autosomal dominant. It's a mutation. It's the most common cause of hereditary thrombophilia. About 50% of inherited thrombophilias. And these will lead to venous thromboembolisms. The other types are antithrombin deficiency. And initially, your PTT does not increase with heparin. And so that's why you might have failed heparin use with underlying antithrombin deficiency. So if you don't have antithrombin to begin with, then heparin won't have any effect on it. It can also be acquired, however, and this is acquired in the setting of kidney disease, so renal failure, nephrotic syndrome. And that's because you're losing antithrombin in the urine. Normally, antithrombin acts to inhibit factors 2 and 10. Protein C or S deficiency leads to an inability to inactivate factors 5 and 8. This increases your risk of skin necrosis with hemorrhage after administration of this anti-clotting medicine, and that's warfarin. So if that occurs, think protein C deficiency. You can have a prothrombin gene mutation. That results in an increase in prothrombin. And just to fully flesh out the mechanism of factor V Leiden, so essentially protein C is normally inactivating factor V. But just like when you have protein C deficiency and factor V keeps going unchecked, you can have factor V Leiden mutation where it's resistant to being degraded by protein C. So then it leads to activation of the clotting factors. Let's talk about blood transfusion therapies. So you can have packed red blood cells for acute blood loss, platelets for significant bleeding and or thrombocytopenia or qualitative platelet defects, FFP and PCC. So these help increase your coagulation factor levels. It's good for reversal of anticoagulation, sometimes used in DIC as well. Now, FFP contains all of the coag factors and plasma proteins. PCC contains 2, 7, 9, and 10, as well as protein CNS, and that's your first line go-to for warfarin reversal, as well as IV vitamin K for their serious bleeding. Fresh frozen plasma takes too long, and it's a large volume to be administered, so it doesn't act as fast in a life-threatening scenario. And you can also use cryoprecipitate, which contains fibrinogens, factor 8, factors 13, von Willebrand's factor, and fibronectin. And these are useful for sometimes in DIC and sometimes most often in factors 8 deficiency like hemophilia or some sort of factor deficiency involving fibrinogen. Blood transfusions, remember, this can lead to ARDS. It can also lead to hyperkalemia from the red blood cells that are lysed, hypocalcemia from all the citrate in the blood, iron overload, and transfusion reactions and transfusion-related infections. And of note, you can increase von Willebrand's factor not just with cryoprecipitate, but also desmopressin. Desmopressin is often used in von Willebrand's disease to stop minor episodes of bleeding. And just of note, you can also use desmopressin not just for hemophilia, but also for central DI. Because remember, desmopressin will be only useful if there are receptors to receive the ADH. Desmopressin can also be used to sleep enuresis. So this will retain water, and this is in juxtaposition to stop the diuresis of diabetes insipidus. This is the exact opposite of ADH antagonists, which are useful in SIADH when there's too much ADH at the V2 receptor. So you can use the Vaptins to treat SIADH in addition to fluid restriction. However, the use of something like an ADH antagonist, like the meclocycline or the Vaptins, can also lead to nephrogenic diabetes insipidus. Just also as an aside, cinacalcet stops hypercalcemia. Basically, it sensitizes your calcium sensing receptors in your parathyroid gland to the levels of calcium in your blood, and that drops your PTH, so that drops your hypercalcemia. Let's talk about cancers of the brain. So brain tumors can be primary or secondary metastases from a second site. If there's multiple, then it's most likely secondary, and the most common sites of brain mets in order of frequency are lung. So lung is the most common site of mets to the brain. Breast, unknown primary, melanoma, colon cancer. Small cell lung cancer has predilection for early mets to the brain, and this is by hematogenous spread. Some primary cancers of the brain include ones that can cross the corpus callosum with necrosis, pseudopalisading, GFAP positive, astrocyte origin, and that's a GBM or glioblastoma multiforme. You could have a fried egg cell, round nuclei with a clear cytoplasm appearance, often calcified, oligodendrocyte origin, also GFAP positive, and that's an oligodendroglioma. You can have an arachnoid cell origin. These have spindle cells, concentrically arranged in a whorled pattern with psammoma bodies and laminated calcifications. And that would be a meningioma. Meningiomas also associated with NF2. They may have a dural attachment, so they have a tail. These are often asymptomatic, occur in the surface of the brain in the parasagittal region. There could be primary brain tumors of the blood vessel origin. These are closely arranged, thin-walled capillaries with a minimal intervening parenchyma, and these are a hemangioblastoma associated with VHL, von Hippel-Lindau. And interestingly, over time, they can even produce their own erythropoietin, leading to a secondary polycythemia where the EPO is high. And then also you can have hyperplasia of a certain type of endocrine cells in the pituitary. Most commonly, these are adenomas. Pituitary adenomas can be active or inactive. Prolactinomas will have high prolactin and usually greater than 200. These will cause amenorrhea because prolactin inhibits GnRH, as well as causing decreased bone density due to suppression of estrogen. And then downstream, obviously, prolactin causes galactorrhea. But if someone has secondary amenorrhea, want to consider, if the LH is low, then it could be because of suppressed GnRH from a prolactinoma. So you would get an MRI treated with dopamine agonists like cabergoline, possibly transsphenoidal resection. And then you can also have a primary brain tumor of Schwann cell origin. This will be S100 positive. This will have biphasic, dense hypercellular areas containing spindle cells, alternating with hypocellular myxoid areas. These are the A-B bands, also associated with neurofibromatosis too, just like meningioma. These classically occur at the CPA, cerebellopontine angle. These can involve cranial nerves 7 and 8.
but they can be along any peripheral nerve. It's often localized to cranial nerve 8, so you'll have some sort of acoustic, internal acoustic meatus, vestibular schwannomas. Let's go back to multiple myeloma. So MM commonly presents with bone pain and anemia, so pallor, fatigue, and subsequently constipation, bones, stones, groans because of the hypercalcemia. Systemic manifestations like fatigue are common, or they might have bone fractures due to the osteolytic lesions. And on labs, you'll see renal insufficiency. And these are because there's congestion in your globs with all the IGs that are fragmented because of the excess production of monoclonal immunoglobulin. So it's a plasma cell cancer, plasma cell dyscrasia. You might also have elevated ESR. That's artificially elevated because of the increased viscosity from the plasma, from all the paraproteinemia, so you'll have a high protein gap. Urine dipstick testing may show elevated protein, but the results are often normal because the protein portion of the urine dipstick primarily detects urinary albumin. So that might not always be helpful. But evaluation of MM begins with a serum or urine protein electrophoresis. The presence of the M spike is highly suggestive, but confirmation requires greater than how much percent of abnormal plasma cells on bone marrow biopsy. And that's 10 or greater percent of abnormal plasma cells confirms diagnosis of MM. If you have someone with MM, it doesn't stop with the SPEP. You also want to get an evaluation for how much of the bone is involved. So you want to get a whole body CT scan, low dose. Also, you could use an MRI or a PET scan, but don't do a whole body skeletal survey with an X-ray. This is as opposed to technetium-99 bone scanning, which is more useful for evaluating blastic bone lesions. MM causes lytic lesions, so it wouldn't be helpful to tag the integration of the radiolabeled phosphate analog. So complications of MM, if it goes untreated, includes the hypercalcemia. This needs to be treated with hydration, dexamethasone, bisphosphonates. Renal insufficiency may need plasmapheresis or dialysis. Infections, so you're at high risk during your first few months of therapy. Pneumonias, UTIs. You want to give prophylactic antibiotics during the therapy to prevent infections as well as any vaccines. Again, the skeletal survey, once that's done with an MRI, PET, or CT scan, you also want to give bisphosphonates to prevent pathologic fractures. If you have symptomatic hyperviscosity syndrome, you want to do plasma exchange, plasmapheresis. And they're at increased risk for arterial and venous clots. So strokes, TIAs, heart attacks, and PEs are also possible. Now, this hyperviscosity syndrome that I spoke about is more common in Waldenstrom's macroglobulinemia, but it can also occur in patients with MM who have high levels of monoclonal IgM. All right, let's do a hemonc meds review. So you could have trastuzumab or Herceptin. These are antibodies against HER2, tyrosine kinase receptors. These basically are used to treat breast cancer and gastric cancer. Trastuzumab, HER2. These cause cardiotoxicity, but these are not dose dependent, and they can cause a decrease in LVEF. You might need to do a radionuclide scan for that. Vemurafenib is a BRAF inhibitor. BRAF is associated with melanomas, and this basically inhibits the mutation of valine to glutamate, the V600E mutation with BRAF. Whereas buricase, mentioned that already, prevents uric acid buildup by catalyzing the metabolism to allantoin. Don't use in G6PD. You can have tamoxifen, which is a selective estrogen receptor modulator. That's helpful in breast cancers because it's an antagonist in breast, but an agonist in the bone. So it blocks the estrogen receptors. So it's good for breast cancer treatment and prevention. Whereas raloxifene is only useful to prevent bone. decay. So raloxifene is for osteoporosis. It does not have an increase in risk of endometrial carcinoma, so you can relax with raloxifene because it's an estrogen receptor antagonist in the endometrial tissue. However, tamoxifen is a risk factor for endometrial cancer. Both of these increase the risk of DVTs and PEs because estrogen increases coagulation factors and it decreases antithrombin 3. So that's also why you can have a hypercoagulable state in pregnancy because of the increase in coag factors and decrease in antithrombin 3. Proteasome inhibitors, these are useful for multiple myeloma and mantle cell lymphoma, which is 1114. These cause peripheral neuropathy and herpes zoster reactivation potentially. These inhibit your cell cycle in G2 M phase and cause apoptosis. Rituximab is the antibody against CD20. It's found on most B-cell cancers, so things like CLL, but it also has other non-cancer associated treatments, so things like rheumatoid arthritis or ITP, but commonly used for non-Hodgkin's lymphoma and CLL. Risk factors with rituximab could increase progressive multifocal leukoencephalopathy. So the CNS demyelination of PML is a risk factor with rituximab. Immediate reaction, transfusion reactions can occur with rituximab. There can also be delayed type 3 reactions with rituximab. Bortezomib are the proteasome inhibitors where you mentioned those. Imatinib, tinibs, tyrosine kinase inhibitors of BCR-ABL. These are useful in treating the 922 translocation in CML. Also, Philadelphia chromosome is not the only target for imatinib. These can also be used in the c-KIT, GIST, GI stromal tumor cancers. Adverse effect of imatinib is edema and fluid retention, can also cause periorbital edema. Cetuximab, this is used in colon cancer. This is a monoclonal antibody against EGFR. Useful in stage 4 colon cancer, wild-type KRAS, as well as head and neck cancers, and weirdly, Menetrio's disease as well. And that's the excess rugal fold hypertrophy. Adverse effects of cetuximab include transaminitis, as well as a delayed type 3 reaction. Erlotinib is another tinib, so it's also a tyrosine kinase inhibitor. This one is also EGFR. It's useful in lung cancer and pancreatic cancer. Most common adverse effect with that erlotinib is the ERL having the rash. And this is because your skin has a lot of EGFR in it, so it'll have downstream effects when you're treating the lung cancer or pancreatic cancer or colon cancer. Bevacizumab is a VEGF inhibitor. That's helpful for solid tumors, colon cancer, renal cell cancer, also used in macular degeneration. In fact, age-related macular degeneration is the leading cause of blindness in the United States. Bevacizumab's adverse effects include hemorrhage, blood clots, impaired wound healing. There can be GI perforation, fistulas, peritonitis, epistaxis. Sorafenib and sunitinib, these inhibit VEGF receptors as well. They can be useful in treating solid tumors like hepatocellular carcinoma, renal cell carcinoma, GIST tumors. Adverse effects include hyperkeratosis or calluses, as well as a rash and hemorrhage. Then there are the microtubule inhibitors. These stop M phase or the mitotic spindles. These are the taxanes like paclitaxel and the crystines and blastines like vincristine and vinblastine. These treat ovarian and breast tumors as well as solid tumors and leukemias, Hodgkin's especially, and non-Hodgkin's lymphomas. Classic neurotoxicity with vincristine, as well as bone marrow suppression with vinblastine. So vinblastine blasts your bone, and vincristine crisps the nerves. Then there are the platinum, these cross-linked DNA. They're good for solid tumors, bladder, testicles, ovaries, lung cancers. Their adverse effects are on the kidneys. So these can cause nephrotoxicity with amifostine prevention, which is a free radical scavenger, as well as saline diuresis with fluids. There's also etoposide and teniposide. These are topoisomerase inhibitors. These prevent DNA from being used, so this increases DNA degeneration. These are also useful for solid tumors, particularly small cell lung cancer, but also leukemias and lymphomas. Major risk factor is, you guessed it, myelosuppression, as well as increased infection risk. Topoisomerase 1 inhibitors, same thing, useful in colon cancer, irinotecan, and ovarian small cell lung cancers, helpful with topotecan. Hydroxyurea, this is used, classically we think of in sickle cell and polycythemia vera, but also is used in myeloproliferative disorders like CML. And this works by decreasing 2,3-BPG, and it's inhibiting ribonucleotide reductase. So it basically causes decrease in DNA synthesis. Then there are the alkylating agents. These cross-link DNA and prevent their use, so it leads to apoptosis. These are the cyclophosphamide, busulfan, nitrosoureas, procarbazine. These are all useful in ablating a patient's bone marrow before bone marrow transplant, leukemias, lymphomas, solid tumors. Nitrosoureas helpful in brain tumors because they cross the blood-brain barrier, and these major side effects include myelosuppression in almost all the cases. Sometimes that's what the goal is, especially before bone marrow transplant. But years later can cause pulmonary fibrosis, CNS effects, toxicity, as well as hemorrhagic cystitis that's prevented with Mesna. In the case of cyclophosphamide, it's a thiol which binds the toxic accretin metabolites. And down the line can also even cause bladder cancer. Anti-tumor antibiotics. These are your bleomycins and your dactinomycin and doxorubicin. These generate free radicals, intercalate with DNA, prevent their synthesis, and decrease the replication. Basically, these are used in solid tumors, Wilms tumor, Ewing sarcoma, childhood tumors, leukemias, and lymphomas. Side effects include pulmonary fibrosis with bleomycin, myelosuppression with all of them, but especially cardiotoxicity that's dose-dependent with doxorubicin. And you want to get that radionuclide scan of your heart function. Make sure you don't have EF less than 30, which would be a contraindication. Reduce the dose if it's less than 50%, and adjust it in case there's any cardiotoxicity, or possibly even stop it. Whereas I think the HER2 inhibitor, trastuzumab, it's dose independent. And then finally, we have our anti-metabolites. So these basically stop the production of your DNA by inhibiting synthesis through different mechanisms. So you have your 6-mercaptopurine, azathioprine. These are purine analogs. So these are good for organ rejection, transplants, if to prevent organ rejection in a setting of a transplant, or autoimmune diseases like IBD, rheumatoid arthritis, lupus. And these are also useful in weaning patients off of steroids if they have steroid refractory chronic disease. Obviously, side effects of this is on your liver, your GI, your bone marrow. You can reactivate latent TB, herpes zoster, or hepatitis. And these are metabolized by xanthine oxidase, so both have increased toxicity with allopurinol or febuxostat because those are xanthine oxidase inhibitors. So you could have someone with gout, and then they suddenly have, they need a kidney transplant, and they're taking azathioprine, and that can actually increase the gout medicines. Allopurinol can increase the levels of azathioprine. Other purine analogs include cladribine, that's good for hairy cell leukemia, CLL, non-Hodgkin's lymphoma. It's not specific, but it basically inhibits DNA polymerase. Cytarabine is a pyrimidine analog. Cytarabine has a long name, arabinofuranosol cytidine. So it actually is a longer name than cladribine, so pyrimidine is also longer than purine. These are good for leukemias and lymphomas, mostly just hematologic. And cytarabine can cause pancytopenia. 5-fluorouracil is another pyrimidine analog. It is used for colon cancer, pancreatic cancer, AKs, actinic keratosis, 5-FU, basal cell carcinoma topical as well. And its effects are enhanced with the addition of leucovorin, which is the folinic acid. It has a unique palmar plantar rash, so hand-foot syndrome with 5-FU. And then there's methotrexate, which is a folate analog, which competitively inhibits dihydrofolate reductase. So that also decreases DNA synthesis. This is used in a lot of things, right? It's used in cancers. It's used in IBD, rheumatoid arthritis, molar pregnancy, ectopic pregnancy, dermatomyositis sometimes. And similarly, it has so many side effects, right? So you want to reduce the chance of those side effects by giving folinic acid, leucovorin. And the side effects are nephrotoxicity, folate deficiency, macrocytic anemias, myelosuppression, hepatotoxicity, pulmonary fibrosis, mouth ulcers. So it runs the gamut. And there's also gemcitabine, which is good for heme and solid. Then there's mycophenolate mofetil, which stops IMP to GMP. This is good for acute and chronic inflammation syndromes. So to recap, if you wanted to summarize cancer drugs and their targets, there's a pretty linear progression from nucleotide synthesis to cell division, right? So the end goal is to stop that cell division. So you can stop it at the synthesis of nucleotides with antimetabolites, methotrexate, 5-FU, 6-mercaptopurine, and hydroxyurea. These all inhibit nucleotide synthesis. You can stop the progression of cell division at the level of DNA. So you can intercalate, cross-link them with platinum agents like cisplatin or alkylating agents like the busulfan, cyclophosphamide, nitrosoureas, or you can intercalate them with doxorubicin, dactinomycin. You can break the DNA with bleomycin, or you can stop the unwinding with topoisomerase inhibitors like etoposide or irinotecan. And if the DNA does manage to get to RNA and then into proteins, and it's starting cell division, you can inhibit cell division by inhibiting microtubulin formation with the vinca alkaloids, or you can stop the microtubule disassembly, and that's with the taxanes, paclitaxel. And you can remember that because the taxanes, taxes, stabilize society.